This is the fourth video of the UTI series, and this is something talking about the diagnosis. So far we have talked about general idea of UTI, sign and symptoms, classification on the basis of UTI, UTI and lower UTI. We have also classified into typical and atypical and or simple or complicated UTI, and we have talked about the pathogenesis. Now we will be talking about some of the investigation. So this video is about some investigation, but before the important investigation that we do is urine examination that is performed on the urine. But before any, before going for in examination of urine, we need sampling. So normally what we do that when somebody presents, a child present to us in ED or in the when we apply sticky bag. So sticky bag is very important to know about it because there is a high chance of contamination. So but if we perform a dipstick on it and we get a negative result, it has a high yield, and negative predictive value in this case is very high. It is almost 99%. So if the dipstick on sticky bag is negative, like almost UTI is ruled out. But if it is positive, then we have to send for culture any of these, like clean cage or catheterized sample or suprapubic aspiration. So normally midstream clean cage urine is preferred, and for this you have to clean the area. In uncircumcised male, some of the authorities recommend that you have to retract the papillae of the if the papillae is not retractable, but actually it's not advised by the NICE guidelines. Similarly, if American Academy of Pediatrics actually recommends that the children who are 2 to 24 months old and they are not toilet trained, you have to catheterize them to obtain a sample for urinalysis or urine examination. But this your different indication. I think clean cage urine can be obtained and in small children, and the one way to obtain is that if you take a swab and soak it in cold water and you rub the area above the bladder, and you just rub it, there is a high chance to get a urine sample, and you can use it a clean cage sample. Okay, suprapubic aspiration is very rarely needed in children, and we can perform, so that when sample is obtained, we can perform either leukocyte, a dipstick which gives us leukocyte esterase or nitrates. So leukocyte esterase is an indicator there are some WBCs are present, and nitrites are indicated that bacteria are present normally because the nitrates are converted by bacteria into nitrites. But it may be negative for certain reasons. For example, if almost bacteria take 4 hours to convert it from nitrates to nitrites. So let's say if somebody has cystitis and he is passing urine very frequently, so nitrite will be not present. Similarly, if there are certain bacteria like which do not metabolize nitrates into nitrites, and in that case will be it will be negative. Similarly, it can give you then we can send the urine for microscopy, and in that case pyuria we define as a greater than 5 WBC per high power field in a centrifuge sample, or more than 10 WBC and an uncentrifuged sample per ml in uncentrifuged sample. And we can also see for bacteriuria. So these two things can be found on the microscopy. Blood can be detected here, yes, on the dipstick. Okay. So while talking about pyuria, we have to talk about two things, that is sterile pyuria and there is asymptomatic bacteriuria. So there is a large, when there is WBC but no bacteria or no culture is negative, we call it sterile pyuria, and it can be in partially treated bacterial UTI and viral UTIs and urolithiasis, renal TB, renal abscess, urethritis, like gonococcal urethritis, Kawasaki disease, interstitial nephritis, and infection in the surrounding structure like appendicitis and Crohn's disease can also give you sterile pyuria. The other important thing that I want to talk about is the asymptomatic bacteriuria. So this can be seen that when the culture is positive, but in on microscopy there are bacteria, but there is no symptoms. So normally they are positive for single organism. Culture is positive for single organism on 2 occasions, and there are no symptoms, then we call it asymptomatic bacteriuria, and it doesn't need to be treated. Otherwise the treatment doesn't help, and if you treat it, it disturbs the microbiome and it can cause problems. So these 2 terms are needed to be considered in here. Okay, then if culture is the gold standard, but when to send urine for culture, that is a question, and for that the answer is 6. There's almost 6 indications per NICE guideline. This is nitrite or esterase positive, recurrent UTI, less than 3 months of age, acute pyelonephritis is suspected, there is no response within 48 hours of antibiotics and there is no sample sent, then you can send it. Clinical symptom and dipstick don't correlate. For example, if somebody have typical symptoms of UTI but the dipstick is not clear and there is no nitrites or eustrine, then you can send. And there is another one indication as per NICE guideline, and this is a very important indication, and this is that with these are the children where they have infants and children which have a high risk of serious illnesses, like they have some underlying condition which predisposes them to serious illnesses. So these are the, like, for instance, somebody is an elder patient, he's on leukemic and he has just fever, no symptoms of UTI, but you can send actually urine culture. So if urine culture is, you take a sample and urine plating can be done within 4 hours, that's good. But if it is delayed by more than 4 hours, then you have to refrigerate that sample. And if E. coli grows on it, we call it a typical UTI, and this is one of the definition of a typical and atypical UTI. So what is the significant count? Colony count in suprapubic, any number is significant, and catheterized, some authorities say that for suprapubic you also need greater than 50,000, but this is a consensus that any number is significant in here. For catheterized sample you need greater than 50 colony forming units per ml, and a clean clutch sample you need 100,000 colony forming unit per ml. No culture should be done on a urine bag or on the sticky bag sample. Thank you so much. And talking about the what is written in the textbook, that is the almost this is a summary, and in addition there is a mention of the complete blood count, C-reactive protein, procalcitonin level. They are common, however there are non-specific marker, and there is another important factor that bacteremia actually correlates with the like you can find bacteremia in younger children, and that could be one of the cause of UTI instead of the infection from the perineum, as we discussed in the pathogenesis. So you can find bacteremia in very young children, like less than 3 months or 90 days, and it decreases as the age grows. So these are some of the important aspects about investigation I want to talk to you about.